Hi, my name is Callie Hatch, and I'm going to do the lab for the chest and lungs assessment. So I will be using this lovely pillow as my model here, and just imagine like that as the actual arms. My assistant here, Luca, is in the picture, so I apologize. So I would walk up to the patient. I would say, "Hi, my name is Callie. I'm here to do a chest examination, just to make sure everything's okay and check out your lungs. Is that okay with you?" I would get consent because you do have to have the chest exposed or touch the patient in certain parts of the assessment. So I would want to make sure that I was clear that was going to occur and make sure there was consent with the patient. I would also make sure before I touch the patient, I'm going to do hand hygiene. I'm going to confirm with the patient their name and date of birth. First, I'm going to go up and look at the symmetry of the chest. I'm going to look a lot here in the sternum to see if there's any protrusion or indentation. I'm going to look for barrel chest, which is often common with COPD patients. I'm also going to look for anything like that is abnormal about the size and shape of the chest, the diameter, the color of the skin. I'm going to look at the venous pattern, the symmetry during inhalation, exhalation. If there is not symmetry, this could indicate things like a collapsed lung or a pneumothorax. I'm going to do superficial venous patterns, or look for superficial venous patterns, prominence of the ribs, and underlying subcutaneous tissue. Normal findings would be effortless breathing with a regular breathing pattern and no accessory muscle use or nasal flaring or retractions. This is seen a lot, especially with kids when they're trying really hard to breathe. So that in and out of the rib cage. I would also check the rate and make sure it's normal for the age, and chest expansion, symmetry on both sides. Patient skin color should be warm pink and no signs of cyanosis or pallor. Abnormal findings would be labored breathing with nasal flaring, use of accessory muscles, and retractions indicating difficulty breathing. Patient may also have pursed lips breathing, which is often seen in COPD patients. Non-symmetrical rise and fall of the chest could indicate a collapsed lung or pneumothorax, as I stated before, and patient skin is pale, could be pale or cyanotic, and if this is a chronic issue, they would have clubbed fingernails. So next I'm going to palpate the chest. I would do it with both hands to make sure there's symmetry on both sides. So not just the one side, I would have both hands up there. Sorry, I'm holding the phone to record. I'm actually going to feel the posterior chest for tenderness or masses, the posterior chest expansion, tactile firmitis, by asking the patient to recite numbers or words. The nurse assesses the area from front to back and side to side and then compares the sides. Again, we're looking or feeling for the symmetry on both sides to make sure that there's nothing that is abnormal. We're also going to look at thoracic muscle and skeleton, thoracic expansion for any pulsations, tenderness, bulges, symmetry, depression, or masses. Unusual movement, sensations such as crepitus. So if I'm feeling here and I feel crackling, it may be that they have a broken rib or emphysema. So that the crackling could be air trapped by the emphysema. Would be something you want to report. We also want to look for tactile firmitis. Tracheal position is important here too, because if their trachea is off to the side, it could mean that there's a collapsed lung. That's severe collapsed lung if their trachea has deviation. We would also look for goiters and thyroid at that time too. So normal findings would be no pain or tenderness upon palpation with signs of masses or crepitus. Skin would be warm to the touch and dry. Tactile firmitis or vibrations while speaking would be normal. Abnormal findings, if the patient is experiencing pain or tenderness, this could indicate trauma, while masses or lumps could indicate cancer or skin conditions such as lipomas or cysts. Crepitus or a crunching, crackling sound in the rib cage area can indicate broken ribs or subcutaneous emphysema. The other thing you may want to look at is like a seatbelt mark here or across here if it's a trauma patient. Also any penetrating wounds, things of that nature, those would be reported immediately. So percussion. Percuss posterior lung fields side to side, identify expected resonant sounds. So the nurse will percuss the interior chest to estimate the location, size, and condition of underlying organs. The nurse should ask the patient to sit with the head bent and the arms raised overhead to percuss the lateral and anterior chest, moving superior to inferior and medial to lateral. The nurse percusses at 4 to 5 centimeter interversions over the intercostal space. The percuss the posterior chest. The nurse should have the patient lean forward with arms crossed and neck flexed, moving superior and inferior and medial to lateral. The nurse percusses at 4 to 5 centimeter intervals over the intercostal spaces. So you could do the tapping to hear for noise. You don't want to do, obviously, in a woman, the breast area or the spine in a patient. Normal findings: tapping intercostal spaces for normal resonance, described as clear, low-pitched, hollow sounds. Abnormal findings: there's dullness, which could indicate fluid or solid tissue. This could be due to pneumonia or atelectasis. Sorry, I can't say that very well. Hyperresonance could indicate trapped air in the pleural spaces. Now to auscultate. Here's my stethoscope. We want to make sure we're using the right side, the small side for peds, the bigger side for adults. We want to make sure this is on bare skin. And when we start, we're going to start top to bottom and side to side. So we're going to start here, listen, have them breathe in and out, full inhale and exhale, then move over. Then we can go down side to side and side to side. You also want to check the actual sides here and underneath the breast line here in the sides. And it's very important that we also go to the back. I can oftentimes hear clear lung sounds until I move to the back. The patient has to sit up. You have to get them undressed, and then you're going to do the same. Sorry about my camera angles here. Do the same side to side, down, 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 side to side. Full exhale and inhale. Sorry, there's my other doggy, is my assistant. Full exhale and inhale with that auscultation. You're going to auscultate posterior lung fields using a lateral pattern. To properly auscultate the lungs, the nurse listens during both inhalation and exhalation from superior to inferior, from apex towards base at intervals of several centimeters, comparing the two sides. During auscultation of the chest for breath sounds, it is important to assess the duration, vocal resonance, and presence of unexpected breath sounds. The pitch, intensity, quality, duration should be noted. So you might hear different noises here than you hear in your bases, and that's important to document. So for instance, you're going to hear stridor up at the top here. If you hear rhonchi, it's usually up in this area up in here. Okay. So you may hear wheezes up here as well. Crackles are usually going to be lower, and normally you're going to hear them in the backside, more predominant. You're not going to hear them in the front. Oftentimes when I listen here in the lungs, I actually hear GI sounds. I don't actually hear the lung sounds, so it's hard to really indicate. So it's really important that we listen on the backside. But you also might hear a pleural friction rub. So that's why we check the sides over here. You might hear a friction rub here. So it's really important that we note what we hear and check all fields of the lungs. You want to identify normal breath sounds, identify or simulate abnormal, or like you might hear crackles, wheezes, diminished. Even diminished is important. It could be indicating the start of an issue, or like pneumonia or atelectasis. That word I can't pronounce, I'm sorry. So normal findings, you should hear bronchovascular and vesicular sounds. You should hear movement of air without adventitious lung sounds. Normal findings would be adventitious lung sounds, including crackles, rills that can indicate fluid fibrosis or early heart failure. Coarse crackles, rails can mean there is fluid or mucus in the large airways. Wheezing upon inspiration and expiration rhonchi or low-pitched snoring sounds, which can indicate mucus or obstruction in the lungs with bronchitis and COPD. Stridor is a high-pitched sound that can indicate a severe airway obstruction blockage, and that's, like I said, up at the top here of the upper blockage of the airways. Pleural rub, described as grating or crackling sounds indicating inflamed pleural spaces rubbing together. Diminished lung sounds or lack of air movement could indicate pneumonia, atelectasis, pneumothorax, or emphysema, especially if it's on one side. It could mean the pneumothorax or collapsed lung or hemothorax, things of that nature. Lack of lung sounds on one side could also indicate airway obstruction or pleural effusion, and that is emergency. So some things that I see a lot in the, sorry, I have my ears on. Some things I see a lot in the ER is I see COD patients that have an oxygen level that's normally below 90. I will always ask the patient, is this your normal? How much oxygen are you on at home? That may indicate whether they're actually having an exacerbation of their COPD. If they're sitting upright in the tripod position, if they're doing the pursed lip breathing, that may indicate that they are in a COPD crisis. I also deal with patients who are having severe asthma attacks. We do breathing treatments, and I also get patients that are full of fluid in their lungs due to various causes, whether it's CHF or fluid overload, or they have bad pneumonia, or they have pleural effusion. I get all that stuff inside my hospital. They may need a thoracentesis, but all of that's important to note and report immediately. Luckily, we have respiratory there. So dyspnea or tachypnea can indicate respiratory emergencies. Just because somebody is breathing slow doesn't mean that that's okay. It could be too slow and below a certain amount. If they're only breathing at like 8 reps a minute, you're gonna have to breathe for them. So BVM, some kind of airway. I also get patients that get oxygen toxicity. So we put them on a mask, blown full of air, and then all of a sudden their stats are dropping. We don't know why. We don't know what's going on. We do an ABG or a BBG. So you can actually give somebody oxygen toxicity. So just killing people with air is not always the answer. So you have to really watch your patients' O2 saturations, get the VBGs, get the ABGs, just to see if they're actually perfusing correctly. Another thing we hear with kids a lot is a stridor. Stridor could be an emergency for kids. It can mean they have swallowed something and there's a blocked airway. It just doesn't mean they're sick and they're, it's not just the barky cough. Stridor can mean that they have a full occlusion going, or almost full occlusion going on. So that is an emergency. And I have seen chest tubes put in so the unequal rise and fall. I've seen it spontaneously with somebody who smokes a lot. I've seen it because of trauma. That usually has more blood in it, so it might be, a hemothorax instead of a pneumothorax. But like I said, we do thoracentesis, we do chest tubes. Those things are all emergencies because the patient cannot breathe adequately. And honestly, we have intubated patients at the hospital. Intubated patients are very high risk for ARDS, and ARDS is an emergency and it has a very low survival rate. I will add some stuff to my presentation so you guys can read up on a little bit more, and hopefully that will assist you in learning more about some of these conditions. And that's my presentation, so thank you.